Welcome back. And before your final session of the day, I want to remind attendees to complete the symposium evaluation. You can access that at the evaluation tab at the top of the screen, and the link should also be pasted in the chat box for you. I'm pleased to introduce Dr. Jeff Ball and Adriana Trent Westby, who come to us from California. Both are at the Psychological Care and Healing Treatment Center in California, where Dr. Ball is the CEO and Executive Director, and Dr. Westby Trent is the Clinical Director. They both come to us highly recommended by MHA board member David Cunningham, who's with Augustine Recovery.
Hello, I'm Jeff Ball. This is Adriana Westby Trent, and we are principals at PCH Treatment. We're doing this talk about best practices for diagnosis, screening, and assessment in a psychological and non-pathologizing model. So, I put in there's an old Bob Dylan song from the 80s that was very prosaic about how everything is broken. Broken lines, broken strings, broken threads, broken idols. No use joking, everything is broken. I'm sparing you all singing it. And so the idea is that our systems have all been corrupted and broken. And I think, largely because of issues of money and power, but all of our current models are really broken. In an ideal world, we do best clinical practice. But in our world, there are cultural, political, economic factors that take precedent. And the other issue we're going to be talking quite a bit about is how mental health care and practice relies upon a largely medical model and diagnostic system that promotes the idea that illnesses reside within the brain and within the individual. And there's very little context involved in that. So this talk, we're going to be challenging the gods of the treatment recovery worlds, which includes American Medical Association, Big Pharma, even Bill W., and the kind of labeling that goes on with recovery. So while there's a supposed adherence to a biopsychosocial model, the biological and medical model dominates. And I hear many, many psychiatrists who say they are biopsychosocial model. In my private practice, when a client of mine would go to a psychiatrist, I can count on one hand over 30 years the times they called me to consult. It just doesn't happen very often, except in a place like our treatment center where we're all working together. So the medical model is arguably the least important influence in conceptualizing and treating most aspects of mental health. And we'll explain more about what that means. And the diagnostic and pharmacological treatment systems are largely based upon a medical model that has very questionable validity and reliability. And we'll get more into that as well. Problems with the medical model in regard to diagnosis and treatment. So as I said, it's the dominant diagnostic framework in mental health derived from medical model is unreliable, it's invalid, it's often stigmatizing and pejorative. Committees of mental health experts who are primarily older white male psychiatrists. I'm an older white male psychologist, so but they sort of do this too. Make decisions on clusters of symptoms making up mental disorders based on very spurious scientific evidence. I put quotes around evidence because there's very little actual evidence. That leads to culturally biased, arbitrary, often invalid and unreliable diagnoses. So you basically have older white males deciding upon what is, go back actually, deciding upon what is normal and what isn't. Yeah. And still go back, okay. And so one example is the chemical imbalance theory, which is the basis of antidepressants. Also, I worked for many years in bipolar treatment, and that was also the basis when I used to teach about bipolar disorder, was an imbalance of serotonin, dopamine. There's no evidence for a chemical imbalance theory. That's been known for 30 years at least. But it's still talked about in pharmaceutical ads. It hasn't been debunked publicly very much at all. There's also 30 years of evidence that antidepressants versus placebos have not been significantly demonstrated. although antidepressants do cause significant negative effects as well as withdrawal effects. And I go back, I heard a talk once about on the DSM-2 where anxiety and depression on the DSM-2 were part of the same diagnosis. And in reality, when you work with people, I've never seen anyone who was depressed who was not also anxious, and vice versa. People who are anxious also have some depression. There was a committee of 14 people, supposed experts who were deciding whether to break them into two different diagnoses. And 5 voted to break them up, 4 voted to not separate them, and 5 abstained. So you had 5 out of 14 people who've decided that anxiety and depression are two separate diagnostic categories. Pharmaceutical companies loved it because they could medicate both separately and then together. But it's totally arbitrary, and that's the basis of most of the DSM. It's a political more than a scientific document. It's voted. There are committees who vote on totally arbitrarily the number of symptoms that make up a disorder, the length of symptoms. So if you can go back to the previous slide. So Dr. Lucy Johnstone, who's a psychologist in England, has written several books around this. And she says, and these kind of quotes kind of capture our philosophy, psychiatry not only fails to address emotional and relationship problems, but actually reinforces them for lack of a whole person, whole system way of understanding them. By using a medical label to rescue people, it takes responsibility away from them, encouraging them to rely on an external solution which is rarely forthcoming, and then blaming them for their continuing difficulties and powerlessness. And we say blaming them, terms such as treatment resistant, non-compliant are all part of that, which we'll talk about. The personal meaning of people's distressing experiences and the psychological and social origins of their difficulties are obscured by turning them into the symptoms of an illness located within one individual. The resulting treatment barriers keep both patients and staff stuck and undermines alternative approaches such as psychotherapy. And there are a couple of other quotes I've included that kind of capture our philosophy. From Hemingway, he said, "The world breaks everyone, and afterwards some are strong at the broken places." And there was another one from Bruce Springsteen where he said, "Everybody's broken in some way. We're always trying to find somebody whose broken pieces fit with our broken pieces and something whole emerges," which is very much, again, our focus is relationship and relational, and that captures that. And the third one, I don't know who said that. There's no cure for the human condition, which is actually mine. When I've had families say, "What's your cure rate?" And I say it's 0. There's no cure for the human condition, but we can help you learn to live with it in much better ways. So diagnostic labels have huge implications. They affect access to healthcare, affect legal issues, affect employment rights. They cause stigmatization and discrimination. They negatively impact self-esteem and openness to treatment. When inaccurate, they lead to self-fulfilling prophecies. And I worked at the VA system for 13 and a half years. I saw more misdiagnosed people at the VA who were never even seen by the psychiatrist sometimes. They just passed on the diagnoses year after year. And these people tended to take on the characteristics of their diagnoses. If they're given medications for them that were inappropriate and treated in that way. So it leads, again, to inappropriate medicating, debilitating side and withdrawal effects, iatrogenic harm. And iatrogenic harm meaning that the medications are actually causing other disorders to be then treated by medication. One thing I wanted to mention too is about psych diagnoses is is the stickiness of psych diagnoses. That if you have a cancer diagnosis and you go into remission and you're cured, you're no longer a cancer patient. You get a schizophrenia or borderline diagnosis, that's with you for life. And so psych diagnoses tend to stick, and which is why the whole question of validity and reliability are so important. So the pros and cons of diagnosis, so we need some kind of shorthand for communication. We need to categorize for clinical research, although it's interesting that the NIMH did not use DSM-5 for clinical research because they felt it wasn't an accurate instrument. And then the main thing we use it for is insurance billing. I was telling somebody I haven't owned a DSM since DSM-3, and someone said, "Do you find them useful?" And I said, "Yeah, they're good for a doorstop, but We do, but I was corrected. We need a DSM-5 to be able to do insurance billing, which is so that's all we really use it for, is in using those labels so people can get reimbursed. The cautions again are stigmatization, self-fulfilling prophecies, as I mentioned, and leading to inaccuracy, inappropriate treatment and medication.
Jeff,
Yeah.
I was thinking we just had a good example of this when we had a client who comes to us with a BPD diagnosis. And clearly, my suspicion is that he actually may have had an underlying mood issue that was not really accurately treated. And so his fluctuation in his mood each day and the behaviors in terms of screaming at staff and just acting out in certain patterns of ways that he's done for so many months now, that for him, when we were looking at those behaviors, the excuse that he had was like, well, I'm borderline, right? And so it was almost like this diagnosis was used as a way and an excuse. It made me think of that when you talked about the self-fulfilling prophecy, that he was acting according to the behaviors that he's read about borderline personality disorder.
Yeah, and I think that's a great point, because I think that label, and I used to lecture about personality disorders. I actually, early on when we started PCH, really didn't believe in borderline personality anymore. And it was hard for a lot of our staff to let go of that label because they'd all been trained in it. I actually think the whole personality disorder construct is flawed. And it ignores context. If you look at the diagnosis for complex trauma, they're almost the identical symptoms to what they call borderline personality. And yet borderline personality carries the connotation when people go online and they read about it, and it says you're going to have it the rest of your life. You might be a little easier to deal with down the road if you have DBT.
Yeah. And what I've also found too, Jeff, is that then there's a population where may not have had trauma, but what gets missed a lot with that is highly sensitive person, the work by Dr. Aaron, where 20% of the population just have a highly sensitive person trait, and it's just the way that your nervous system experiences the world. And my suspicion of this gentleman was exactly that he was growing, that was part of his presentation, that he grew up and 80% of the world, including his family, are not highly sensitive people. And so when he's having these experiences in terms of just how the senses are experiencing the world, and he is heightened in his mood because of all of the income and sensation, and the parents don't know how to handle it. So they've not been able to help him curb some of the behaviors and learn how to manage and navigate in the world. And so, of course, the way that he then approaches relationships and gets easily triggered by things, got diagnosed with borderline personality disorder. So it was really difficult for him to access the treatment because he wanted treatment for borderline personality disorder, right? That somehow there's the belief that if I have this is the treatment for that. So it was really difficult for him to access treatment. And that's one way how labeling and diagnosis sometimes is not helpful.
Exactly. And I would even argue that he did have trauma, but it was small t trauma.
Yes. Yes.
When someone, and I think what's inherited is disposition, which is the way what you're saying. Some people have much more sensitive dispositions. They become the artists and the musicians and the actors, and it's not a negative thing.
Yeah.
But they are much more sensitive to misattunements in the world. And so a parent who just doesn't get them and doesn't, feels like they're overly sensitive, that to be called overly sensitive can be traumatizing.
You're right. And especially to a highly sensitive person, right? That the experiences that one person might have that may not be experienced as traumatic for somebody with a highly sensitive trait. Yes.
I think it also explains why people will say, well, their brother is fine. Now, in a sense, they're growing up in two different environments, even though it's the same household, because one has a very sensitive disposition and one doesn't.
Yes.
So the same thing that rolls off one's back doesn't for the other.
Right, gets stuck within the nervous system.
Mm-hmm.
Yeah.
Okay, so the DSM-5, if I haven't trashed it enough yet, so it's the Diagnostic Statistical Manual for diagnosing mental illnesses. At PCH, we don't accept the concept of mental illness. The concept of mental illness does not have a scientific basis. It's largely culturally determined by a bias of what constitutes normality. Human experience, such as sadness, anxiety, rejection, ambivalence about cultural norms, is medicalized and pathologized as disorders. And the DSM is extremely biased by the psychiatric industry to over-pathologize human behavior and experience and perpetuate big pharma and over-medication. And, you know, the pharmacological industry was heavily involved in helping develop the last DSM. They fund all the drug research. They falsify lots of drug research. They cut out any kind of negative findings if they can when they present. Yeah. So anyway, that's the basis of the DSM-5.
Yeah, one quote, Jeff, that sticks with me was by, let me see if I can read this. It says, this was by Alan Francis. He was the psychiatrist and former DSM-4 task force chairman in April 2015. He says, mental illness is terribly misleading because the mental disorders, in quotes, we diagnosed are no more than descriptions of what clinicians observe people do or say, not at all well-established diseases.
Okay, so issues with the medical model of psychological distress. So the disease model is misleading, in many cases meaningless. It doesn't fit the definition of what a disease is. It's unscientific, it's unhelpful. As we've said over and over, it leads to stigmatization, discrimination, marginalization. You know, one thing, culturally it's so biased, you know, people of color tend to get more severe diagnoses than others, and then tend to be over-medicated more. So there's a huge element of social control in all of this. And as I mentioned earlier, there's much more stigma to have a, quote, mental illness than a physical illness. And there's no good evidence that psychological issues are biological or genetic in origin. I read that the 97% of DSM diagnoses have no demonstrable biological or genetic basis. I used to teach abnormal psych for 30 years. I always hated the term. You know, I always say, plane crashes, it's not abnormal physics. When people crash, it's not abnormal psychology, it's their psychology. And so I used to teach about genetic studies of schizophrenia and about these studies about, which I think I get to, so that, you know, the twin studies, the implication was there were identical twins that were separated at birth, raised in totally separate environments, and had a high concordance rate for schizophrenia. The reality is, and a book just came out, I think in the last couple of years, saying what these studies really were. Many of them were raised in the same household till 5 or 10 years old. Many were sent to live with other relatives. Many grew up in the same neighborhood, so they would see each other all the time. So there were huge confounds in these studies that were never reported. So, as I said, the genetic evidence is dubious. It's unclear whether biological, quote, abnormalities are necessarily caused by biological factors. You know, and I see this a lot in a lot of the psychiatric research where correlation is confused with causation. There are lots of correlations. You know, the latest one I've seen is that, you know, marijuana is so strong it's causing psychosis and schizophrenia. And the reality, there's no evidence of that. You know, most people who smoke strong marijuana do not develop psychosis. But it is true that those kind of drugs are disinhibiting, just as alcohol is. So if those in there, people can create more stress, and stress and disinhibition can lead to those kind of symptoms. So it's much more likely that's what's, you know, sort of behind it. The role of dopamine. I used to teach about the dopamine hypothesis. And, you know, the idea that there was excess dopamine in the synaptic cleft, which is what caused psychosis and schizophrenia. It turns out that dopamine it's all over the place. Lower dopamine. Some people who have higher dopamine are just more creative, and it's also affected by environmental factors. Trauma, sort of releases more dopamine as well. And making creative links is that unrelated things utilize dopamine. So the more creative someone is, the more they're utilizing their dopamine. The biological differences between those experiencing psychosis are small and insignificant. And the dopaminergic pathways are influenced by many things, including trauma and abuse.
It's interesting you said it, because I remember when my brother was first diagnosed with schizophrenia, about almost 25, 30 years ago now. I remember just learning about this in school and thinking, oh my God, this is it. This is the explanation for it in terms of the dopamine, hypothesis.
The elephant in the room, as we call it, are the environmental experiences. They clearly alter our brain biology. They're largely ignored, certainly by the DSM and by medicine to a great extent. So a non-medical approach to reducing stigma and discrimination is likely to be more effective and helpful. And there are volumes of scientific evidence that social factors lead to mental health problems. Much evidence that social factors such as unemployment, physical and sexual trauma, poor housing, social disadvantage, all contribute to poor mental health. It's again, giving someone a numbing agent or an antidepressant is not going to help them if they're unemployed or they're homeless. In fact, it may hinder them from being able to recover from those kind of places. So social economic factors are strong predictors of mental health problems, but they're largely ignored in the current mental health system. And largely because they require, large amounts of money and large social change, which we can see the resistance to that is huge. So poverty, deprivation, child abuse, social isolation, all lead to distress and are diagnosed as mental disorders. And, related to that, I always think of the pandemic, talk about social isolation where we were in lockdown. I read this article. There were actually several articles like this, how the incidence of mental illness had increased during the pandemic. One of them said 6 out of 10 young people are experiencing anxiety, depressive, and obsessive compulsive disorders. And my reaction to that was, I'm more curious about the 4 who didn't have those symptoms.
Right.
The 4 out of 10, because the reality is all of us were more anxious. There was a deadly virus that we didn't know anything about in the beginning.
Yeah. Right. It's like a natural response, right?
Exactly.
Yeah.
We were all, it was depressing, not being able to go to work, not being able to see people. And we were checking everything. We were wiping everything down. We were super vigilant. All of us had obsessive symptoms, and there were adaptive ones. Right. So the idea that somehow these were mental disorders that needed to be medicated were, very questionable. And it's the best example of that, I think. And again, I think the research shows, more abuse, deprivations, and stress one experiences, they're going to experience mental health problems, which seems pretty obvious.
Jeff, and I also remember you were talking about a study several months back, just about that was done, where increasing the
it was an epidemiological study in 2018, I believe, over 21 years, and they looked at suicide rates, and they looked at the minimum wage, and raising people's wages by $1 lowered the suicide rates by about 5%, and raising it $2 lowered the suicide rate from somewhere from 7 to 10%.
Right.
So again, it's a great example of an environmental influence and kind of looking under the light to see what's wrong.
Right. Context.
Exactly. And then by a focus on spurious evidence of genetics or biological causes of mental disorders, environmental and social factors are largely ignored. So, we spend probably billions researching MRIs and looking for brain changes in terms of suicide and everything. And again, social factors are much more likely to be what's causing these kinds of problems for people, but they're largely ignored.
Right.
And what was that last line? That last one. Mhm. Oh, that the disease models, you say, results in an assault the system inflicts upon vulnerable people. So problems with assessment and diagnosis, and the way assessment's often confused with testing. Testing's a part of assessment. We consider assessment as a long process where you're constantly compiling data and information about people to better understand them. And so it's not just about, I have literally seen a 5-minute meeting where someone's given a very severe diagnosis. And that's not how we do things. I think that's what leads to more poor validity and reliability. So lack of a thorough evaluation. What's your family situation? What kind of medications and drugs are you taking? Because it may be it's very common that people who are on polypharmacies, that many of the medications are causing many of their problems. In fact, Robert Whitaker, if people have read Anatomy of an Epidemic, talks about how, I think from the introduction of the Prozac and the antidepressants, the SSRIs, that the incidence of quote, mental illness has increased rather than decreased. And he makes the point, if these drugs really work, shouldn't it be going the other direction? So, again, this idea of what are these medications doing? We have found in our program, trauma is the basis of many of our conditions that we were looking at. Probably almost everyone has experienced some kind of trauma, even if you've been hospitalized in a psych hospital. That can be a traumatic experience for people.
Right.
It needs to be worked through. The clinical gaze is an interesting concept. It's very prevalent in medicine, and it's this idea of, first of all, if you notice, we keep referring to people as clients and not patients, because patients are a very medical model view. They imply a power differential, and the clinical gaze is the way that doctors are sort of trained to look at patients, which is as a kind of a collection of symptoms as opposed to a whole person. I bring up, when I was at the VA, a medical director called me over one day. We had a patient who was in the medical setting who was this former New York stockbroker who was really grossly obese, really kind of abusive. And he had these horrible sores on his legs. And she calls me over, and she's doing rounds with the psychiatry residents. And she said, Mr. So-and-so just threw me out of his room. He won't take his medication. Can you go talk to him? So I go in and I said, so what's going on? I hear you just threw them out. He goes, that bitch, she's trying to give me these I had terrible side effects from the other medication you gave me. I'm not taking anything. And I said, okay. I said, she wants to give you something else that may not have those negative effects. I don't care. I'm not taking anything. I said, look, you're the one in pain. Stop cutting off your nose to spite your face. Take your fucking medication. And he says, fine. So I go out in the hallway. I said, you can go back in. I'll take them now. And she said to me, God, what did you do? Like, I was this miracle worker. And I said, I have a relationship with him.
Mm-hmm.
And that was all it was, the only difference. And so I could speak to him in his own language.
Right.
And he was more amenable to that.
Right. And he trusted you because of the relationship that you
exactly had. And I think, we'll get to we think where medications are useful is wherever it can enhance that relationship and not take away from it. Because the relationships are where we think people heal. So again, a conflict between listening and seeing. And whether you're really listening to someone and hearing what they're saying, and viewing the patient as a disease, and not as a person, which tends to be that kind of clinical gaze. I did a talk on this, and I had a little video of the film Frankenstein, and how in the book by Mary Shelley, Dr. Frankenstein refers to his monster as a collection of parts, basically. And in the film, I had a clip where the Boris Karloff is like pleading to be seen.
Mm-hmm.
by the doctor, and he will not. You know.
Right.
So the other thing is, the idea, we try to look at what happened to you versus what's wrong with you when people come to us. So there's a great TED Talk by Elizabeth, gosh, I'm blanking on her name right when I need it. She was a young woman in Britain who was diagnosed schizophrenic, was on lots of medications, was doing terribly. She'd been a star student in college, and that's when the break happened. And she finally, after many years, saw a psychologist who encouraged her to get off of the medications and started treating her trauma, which was significant.
Right.
And she fully recovered from that. And now I think got her master's in social work and does talk. She's part of the Hearing Voices Network, which is a really great group.
Yeah.
And then, the idea of type 1 and type 2 errors, again, kind of confusing. Well, that's something it's a long thing. I won't get into. I don't know, Adriana, do you have anything about that? So let me talk about the alternative to the current diagnostic system that we use at PCH. So, people say, well, you have to have a categorizing system. Our view is we don't label people, we label experiences, and both emotional and cognitive experiences. So under the current system, I talk about normal, which I always put in quotes because I'm not sure what normal means.
Right. Who defines normal?
Well, and you can't, in our current culture, the one we grew up in, it's impossible to not have conflict and not be incredibly stressed out and everything else. So, there's a great story that Freud told where he said in his whole career, he treated one patient who made it through all 5 psychosexual stages of his, which would imply normality. And he said he found it very boring. So the idea is that, most of us have some anxiety or go into neurotic states, and there's something to be said for that in terms of making us more interesting, probably.
Right. And I was thinking, Jeff, like just normal, right? You talked earlier about just how the people in terms of mostly older white men defining this system, right? So normality is seen in this very limited scope that it really does injustice to most of the human experiences that would not fit within this very small scope of what normal is.
No, exactly. And it's, I think one of the things I meant to talk about earlier is there are a lot of views of people and, a lot of windows you can look through. One of them is a medical window.
Mm-hmm.
Unfortunately, that's the predominant one that we use, but there's a psychological window, there's a sociological window, there's an anthropological one, and you'll find behaviors in one culture are very normal
Right.
versus another culture. In some cultures, it's very normal to be paranoid. It's protective.
Mm-hmm. Mm-hmm.
In kind of dominant culture, it's seen as pathology. So if you're not looking through lots of different windows, you're missing the whole picture, basically.
Right. And I wanted to clarify too, Jeff, is that we're not knocking the medical model. We think the medical model does a good job for medical problems, but it's the fact of trying to superimpose the medical model for psychological experiences and other human experiences is where we are running into the problem in diagnosis and labeling.
Exactly. So, the idea is this is sort of a layered, as opposed to kind of the vertical system of the DSM, where there are these discrete diagnostic categories. This is more as though, sort of different layers of experience. So, as I said, the top layer is kind of normal anxiety, neurotic states below that, which, again, all of us go into at different points. Depressive states. It is not abnormal to be depressed sometimes. And there was a great Twitter tweet I saw where a woman said her husband had died and she'd spoken to his psychiatrist and, she reported she was feeling depressed. And the psychiatrist said, well, I can give you something for that. And she said, well, aside from the fact that I think that's part of what killed my husband, aren't I supposed to feel depressed? My husband just died. And
Right.
she said, she said, yes, but you don't have to.
Yeah.
And I think that captures the difference between the pharmacological approach and our approach. I think you do have to.
Yes.
There was a great paper by Winnicott where he talked about the value of
Value
depression,
of depression. Yeah.
and where depression is a developmental kind of milestone that people reach. And, that you have, it's object related, and it's about losing an object, and how that's a healthy thing to work through. And I think, my own private practice, which I did for 30 years, I would have clients of mine that would get a new job and they'd want to try an antidepressant. And I would usually discourage them. If they were getting into the office and working on their issues, I didn't feel they needed it. In fact, I felt like it might dull them enough or numb them enough where they would lose some motivation to figure out what's going on. And I do think that happens. That, I think they can be helpful if someone's unable to get out of bed and make it into therapy. So, you can use an antidepressant or some other kind of medication as a way of enabling a relational, a relationship with a therapist, for example.
Right.
But as a standalone, I don't think it's ever that helpful. In fact, it increases suicide rates.
Yeah.
So, and also there's severe, for some people, really terrible withdrawal when they've been on them for a long time. So those are depressive states, borderline states. I said, we define borderline as someone gets triggered, they're highly labile. I always say they go 0 to 100 rather than 0 to 20. They have mistrust and relational issues. And, the reality is that all of us have these triggers. I have my triggers that where I'll start thinking very black and white, get very dysregulated. Now, hopefully they don't last very long, and there are much fewer triggers than the people that we work with. The people we work with get triggered much more easily. They have a harder time getting out of it.
Right.
But it's not as though they're sort of a different animal. It's not as though they're qualitatively different.
Yeah, or that it's untreatable, right?
Well, that's the other piece. And I always feel like Linehan did somewhat of a disservice in making, Kernberg used to talk about different levels of borderline states and more of that kind of reaction. She made it into a thing where you're a borderline personality. And so have the mentalization folks. And I actually heard Peter Fonagy say to me, I was asking him a question about it. He goes, these are not just trauma patients, they're different than you and I. And I couldn't disagree more. I think these are highly sensitive people who have had trauma, and this is their reaction to it. And so, we work with them on lots of ways to help regulate better and help trust more through good therapy. And many people we work with leave our center, they wouldn't carry that diagnosis anymore, even though they've been told you've got it for life, basically.
Right.
So those are borderline states, dissociative states. And again, the most extreme example is a multiple personality. And it results from severe early child sexual abuse in almost every case I've ever seen. And, I'm talking age 3, 4. And the reality is that we all dissociate. It's a natural defense. I always say, when you're driving to work every day, how many don't remember the ride? You're dissociated to an extent. Hopefully, I always say, I hope you're not dissociating right now. But, the multiple personality is an example of an extreme dissociative state where if you're a small child who's being sexually abused by a parent or someone close to you, it is incredibly adaptive to be able to dissociate and leave.
Right.
And so they when it's really severe, they create other personalities that can manage and handle the abuse.
Right.
And that's a very adaptive defense at that point. Where it becomes less adaptive is later in life when those particular events aren't happening, they get triggered and they go into a dissociative state. So, we help people again try to bring the past into present reality and try and understand and work that through.
Right. And just to clarify, the multiple personality that you're talking about, which is currently the DID, dissociative identity disorder. Yes.
Yeah, and again, I have a problem with the term disorder. That, again, it's it wasn't a disorder when it developed. It was actually, adaptive functioning.
Right, right. It was helpful behaviors. We tend to look at just at PCH, as you know, look at these issues as problems in living. People are having problems in living the kind of life that they want to live, right? And things are getting in the way, and so we want to tackle those, whatever those things are.
Yeah, in the current model, particularly with more severe mental conditions, they tend to over medicate. The quality of life, if you have a schizophrenia diagnosis and you're put on heavy antipsychotic medications, quality of your life's pretty awful. And one thing that Whitaker talks about was there's a World Health Organization study that showed that people being treated in developing countries, non-Western countries, for schizophrenia do better than they do in the Western world. And the reason is they use medications more sparingly and acutely. They don't keep them on them for a long time. So people have much better outcomes than they have here, which is pretty telling.
Yeah.
Again, when I worked at the VA, there were lots of guys shuffling along for years, and their lives were pretty empty. So it's very sad when that happens. And our goal is to get people functioning and living as contented a life as they can.
Right.
So, and then psychotic stage is interesting because even schizophrenia is being questioned now as kind of a garbage category for anybody with any psychotic issues. And so there's a real question about whether, that's really an accurate term. And, I also heard a guy speak who's getting his PhD who was mislabeled or, was labeled schizophrenic on medications, got off of them. And he'll say, how many feel your cell phone go off in your pocket and it's not there? Now, I've had that experience many times. That's a hallucination. And, that again, all these things are on a continuum. We all do these things. We all experience these things in a different context and not as severely as most of the people that we treat.
Right.
But if we were to sleep deprive all of you for 4 or 5 days, you'd be hearing voices and seeing things and all of it.
And I was also thinking, Jeff, there are times where, certainly not a lot of times, but a few times where I might hear somebody call my name and I'm like, or looking at my kids, I'm like, did you just call me? They're like, no. Right. I'm like, oh.
They're just gaslighting you.
Right. Yeah. All right. So we're looking at the problems with just, again, the pharmacological approach to treating behavioral health problems. And Jeff alluded to this earlier. Again, there's just an overprescribing and over-medicating of just America in general. I believe it was in 2013, there was an estimated 40 million Americans on some kind of medication. That's like 16.7% of the population taking medication. And when we look specifically like at ADHD and attentional problems, that too is just so just heavily diagnosed, especially in young kids. I was just thinking about kids as early as 2 years old or as young as 2 years old, Jeff, being given the diagnosis of ADHD and then being put on medication. I remember my son, when he was in 5th grade, just having a lot of energy. And, you could see in his class where the little girls are just lined up because, girls tend to develop more before boys anyway. And so little girls are like standing in their little lane and their line. And of course, a few of the boys, including my son, are just like hopping on one foot, jumpy and, doing their thing. And I remember the teacher at some point, and he was very vocal and verbal. And at one point, he was having an issue on the playground. And the teacher, I guess, had a conversation with him and asked him, she was like, Alex, what can you do to help, to feel better? So Alex thought about it, and I guess he felt better for the day, did whatever he was going to do. And then the teacher dropped him off to the after-school teacher and was relaying the fact that Alex had a bad day and was saying, that Alex did not do better. She had a conversation with him earlier. Alex raised his hand and said, excuse me, you asked me what I could do to feel better. You didn't ask me if I would do better. So you have this little 5-year-old who is just so verbose. And of course, the teacher seeing his behaviors as a problem. And I just remember fighting with the school. And this is a teacher then suggesting to me that my kid should go on a stimulant medication. Of course, I fought that and with the school and had the teacher go get some, resources and training in terms of how to manage. And now I have this beautiful, resilient 16-year-old in high school, straight A student, level 9 gymnast, who is gifted, right? But had I listened to and had I been a different mom, and especially as a mom of color with a little Black boy, thinking, oh my gosh, and all the stressors about what that means for him as well in terms of the school to prison pipeline and having to think about that, I would imagine sometimes a lot of mothers of color may opt to providing or going with the teacher's recommendation of putting their kid on a stimulant, which I just unreal at that age.
And the other thing is those stimulants, research has shown they help control behavior. They don't improve academic performance at all.
Yeah.
Which is kind of to your point of what your son said to you at 5.
Yeah.
And
Yeah.
I had the same experience where, my kid, I have 2 boys and who are now 14, but a couple of years ago, or several years ago, one of them has a lot of attentional issues.
Yeah.
And pediatrician, of course, suggested, some kind of stimulant, which she knew who she was talking to. And basically, he started using it as an excuse. So I'd get on him for something and he'd say, it's my ADHD, Dad. So then I found an article written by an expert in New York that talked about how there's no really such thing as an ADHD diagnosis, that the school system is better built for girls, that boys often have a harder time, and that basically we're talking about a reaction to an environment. If you change the environment, it goes away. And there was a study, I believe it was in Finland and replicated in Texas, where they increased recess time. They doubled the recess time, and the incidence of ADHD practically went away.
Yeah.
So, and I find with my own kid, it's like, if he has more outlets, he is able to manage his attention in better ways.
Yeah.
Another example of that is he was playing, another diagnostic thing. He was playing basketball one day. I'm trying to get him to come in for dinner. And he goes, as soon as I make my last shot. And he's trying to take 30 footers, falling away. And I said, you're never going to make that shot. It's going to take, you need to come in now. He goes, it's my OCD, Dad.
Right. Talk about
psychologist.
Excuses, right? Using
and
the
it becomes an excuse. Just like,
Yeah.
I'm sorry I put a brick through your windshield on the borderline,
Yeah.
It was an excuse. I have OCD. I have to, and I said, well, then coming in right now will be a good exposure for you to be able to
Nice.
tolerate your anxiety. So he couldn't win. Anyway, go ahead.
Nice. Yeah. And then the other class, of course, benzos, right? It's just so many people on benzos. And part of the issue with benzos is that it's just so addictive. We do not allow our clients to remain on benzos at PCH. So clients need to agree if they're coming in on benzos to be able to be tapered off. Or to go to detox first in order to access treatment. It really just numbs the internal experiences, which is the very thing that we are trying to help clients to come in contact with so that they can develop the skills to navigate those internal experiences and not medicate it, right? Take it away.
The other problem with benzos, I'm just going to say, is they help your anxiety in the short term, and they make it worse in the long term. And what I mean by that is you take a benzo, you calm down in the moment. When it wears off, your anxiety is even higher, and so you take more. And they're incredibly addictive. The withdrawal from benzos is worse than opiate withdrawal.
Yeah, and we're not saying that benzos are not useful in the short term or in certain cases, right? That in terms of you're having to do a 12-hour flight and you have to work the next day and you need to sleep, or in certain short-term cases, medically, might be appropriate. But
I had to do an MRI, which made me really anxious because the thing's right on your, you're in this tube. I took a Valium before, and it helped.
Yeah, right. And so it's meant for short-term use, but it's being publicized and used for long-term treatment of any kind of feelings, right? Numbing out. And then Jeff talked about, again, antidepressant. I always have a problem, like Jeff, with the word antidepressant. When I think antidepressant, right, I think antibiotics, right? We're trying to be like the medical model. And if antidepressant really were like antibiotics, like an antibiotics take away whatever it's treating, we should not have more cases of depression. And since the invention or development of antidepressants, we've had more cases of depression. So something is clearly not working. In terms of placebo effect, I can't remember the exact percentage, but it's anywhere between like 35 to 40% expectancy that you're given something that will help you will lead to you reporting better outcome. So we always say placebo is, the effects are underrated, but placebo effects is actually pretty powerful. In terms of opioids, medication like, Suboxone, et cetera, again, clients are needing to taper off of those medications. We're not saying, again, that they're not helpful in short term. Actually, I just had a medical procedure. I had my first time going under some kind of sleep last Friday. And when I looked at my medical paper afterwards, Jeff, I'm like, oh my God, they gave me fentanyl. I'm like, right? But that was what was used. And it worked. I don't remember anything, recovered quite fine under the supervision of the nurse and the doctors. So again, it has its purpose, but just not the way that it has been abused within the mental health world. Most people can go to a psychiatrist who will see them, as Jeff was saying, sometimes 5-10 minutes. Not all psychiatrists. There are some good psychiatrists out there, especially the ones that we work with. But it's just, you can just go and get these medications very easily. And we're not teaching our citizens about just the normality of having internal experiences, your thoughts, your feelings, your urges, sensations, memories, all of that. Those are just natural human experiences. And instead of trying to run away from them or trying to medicate them, how do we come in contact with them and how do we manage them? Part of the issue, again, with just this pharmacological approach is the improper prescribing. So in terms of, bipolar, there's sometimes a lot of times we're dealing with people with trauma or other issues, but they might be diagnosed with a different diagnosis and then given medication that's completely inappropriate.
If I can chime in, the one of my pet peeves about the newest DSM are all these spectrum disorders.
Yeah.
Because I think what they do is they create a broader umbrella that you can diagnose people under and medicate them with.
Right.
So, for example, every quirky kid is now autism spectrum disorder. Anybody who's got a sensory issue goes into that category and then is required to have 5 days a week ABA treatment or whatever they do.
Right.
Bipolar too. I worked with bipolar for years with people who were hospitalized who were truly manic and bipolar. Now, anybody who's dysregulated, we get diagnoses where someone, Scott will say, well, the person, within the same day, they'll have 3 different mood states. Well, that's not bipolar. That's usually trauma and dysregulation. Bipolar is you'll have several days of mania followed by deep depression. And a little bit less if you're bipolar 2, you're not having to be hospitalized, but it's not a totally different thing. And
Right.
I think because there's no medication for trauma,
Yeah.
Psychiatrists, their only tool are meds, and they'll say, oh, they're bipolar 2, and they put them on mood stabilizers. And then they have iatrogenic damage because those aren't the appropriate medicines. They put them on more medicines.
Agreed, right? For the side effects, which we don't use at PCH, we believe that these are negative effects of the drugs. But when you use the word side effects, it minimizes, right, what all the effects that the drugs have on your nervous system.
We always use the example of those pharmacological ads on television too, which are constant.
Mm-hmm.
And they list these sort of side effects. They're all just drug effects. They're not, they're only listed side effects to minimize them.
Yes.
But they're severe often.
Yeah, agreed. One thing I forgot to mention in terms of antidepressant, Jeff, is that there's a lot of research that there's some effectiveness for when you're having major depressive symptoms. You can't get out of bed. It could potentially help to lift that so you can actually get out and access treatment. But very, very little to no impact when you're dealing with mild to moderate depression. And so there's just a whole, this is why, again, the antidepressants are not effective, but of course the pharmaceutical company won't publish those particular data. One thing we do know with the SSRIs, however, we've seen clients and studies show, especially those who are struggling with obsessive and compulsive issues, somehow antidepressant, even though it was not made to treat that, somehow have good effectiveness for that, for those cluster of experiences.
Probably because they disrupt that ruminative thinking and that kind of circular thinking.
Yeah, yeah. And then the other 2 points we already reviewed, which is the biological basis and chemical imbalance theory has been really debunked. And then placebo effects, yes, being underrated, right?
Yeah, I always say, when they say, well, antidepressants are more effective than placebo. Placebo are basically expectancy effects that
Right.
someone you're going to for help is giving you something to help you. I think psychotherapy has probably strong placebo effects as well, but I think placebo's taken such a negative connotation, and it's basically you're basically providing something for the mind to be able to heal itself.
Right.
And to me, that's what it is. And I wish they would change the term because it has this connotation like it's nothing.
Yeah. Yeah. And it's very hard to parcel out placebo effect when you're doing any kind of medication research, because you're going into a research, whether it's a placebo pill or the medication, right? There's placebo effect across those conditions. So how do you then rule that or account for that in those?
And that's where they'll compare kind of the inert agent with the active one and see if they get the same effects. And they used to get a slight therapeutic effect from antidepressants over placebo, but they weren't really blind studies because of the side effects. Both the physician and the patient would know that they were on the active agent.
Right.
So what they did was they put in active placebos that had side effects, and then they found no difference between the two. Yes.
Right. So then after all that, so we kind of like, okay, these things don't work. So actually what does work? We believe, again, in the model, truly the psychosocial model for well-being and best clinical practice. It's really about, again, the psychotherapy and the relationship that the clients establish with their therapist. And there's been lots of research actually that therapist characteristics really does contribute to, is and associated with outcomes in terms of therapy. Now, we can't say actually that if you're diagnosed with OCD or you have this, that this is the treatment type that's going to work for you. That again, in terms of providing the kind of treatment that PCH provides, the model really is much more complex. We know that each body's nervous system is so unique. We don't know what treatment combination is going to really work. So we throw everything at our clients, and they have the options of trying many treatment modalities and kind of see which one helps to help them manage the experiences that they're having that's getting in the way of them living their lives. So we use what are called top-down approaches, which are approaches that strengthen the thinking brain that can help you regulate your emotional state from the top down. So those can be things such as insight-oriented therapy. We're looking at, CBT, dialectical behavior therapy, skills building, anxiety management, acceptance and commitment therapy. And then we're also using what are called bottom-up approaches. Those are approaches such as somatic experiencing therapies, sensory motor psychotherapy, yoga, it could be breath work, it could be movement, drama. So anything having to do with movement, breath, and touch. Not us touching clients, but they can learn about different things and ways of touch that is soothing to their nervous system. And the reason for that is that there are times, and many of you actually may have the experience, when you become so emotionally activated, your thought process, you really can't use your skills to really regulate your nervous system. And so we're trying to help our clients have both approaches so that they have different options and arsenal in their toolkit when they become dysregulated or have experiences that are really difficult to manage. So then how do we improve our mental health systems in general? Here are some solutions that we have considered. Really, it's about taking the time to make the proper diagnosis, right, of emotional and cognitive states within context, trying to avoid what Jeff was talking about, this clinical gaze, finding out what happened as opposed to what is wrong that he talked about earlier, and really trying to avoid stigmatization and just these lifelong labels. And truly looking at how do we approach this from a psychosocial model, not a medical model, when we're dealing with issues having to do with psychological issues and problems with living, okay? And then providing the least invasive and effective treatment alternatives, okay? So these are all different options. Like I was saying, you don't really know what combination of treatment is going to be the right combination for your specific client. So really providing alternatives, both top-down and bottom-up approaches, so that clients can try these on, use them, and determine what works for them, right? Jeff, can you talk real quickly about Beau Bartlett's 10 do's?
Yeah, I'll see how my memory is. So Beau Bartlett is an artist, pretty famous artist who's based in Georgia, who I've painted with. And he actually, we have a whole arts program at PCH that was largely kind of motivated from my working with him. He did something called a holistic art workshop with artists, where you start off doing yoga, you eat healthy food, you paint, but it's a very balanced kind of approach. And so he has these 10 do's on his workbook and his website that we incorporated. So there are things like hydrating, healthy foods every day, doing some kind of spiritual or meditative practice. So we do mindfulness meditation, for example. Doing some kind of art every day. And we have a full arts program that is not by therapists. We do art therapy as well. But the arts program is the idea that, and I told our clients, it regulates me when I'm painting. I don't look at my phone 15 times. I'm not distracted. And so we're looking for tools to help people better regulate and manage their lives. And we found art's a great one.
Right.
What else is there? There's having good therapy. There's some kind of insight-oriented work every day. Making money is on his thing. So it's important to have a job and to be, have a purposefulness in life.
Yeah.
What am I missing of those?
That sounds, yeah. I'm sure some of them.
No, exercise.
Exercise, yes.
We do aerobic exercise.
Yeah.
We really push it because there's research that shows aerobic exercise works better than antidepressants.
Right.
Or anti-anxiety meds.
Right.
We do yoga several times a week because there's research that shows it helps with trauma, regulating body rhythms. So
Right.
it's really kind of a very holistic, in the best sense of the word, multi-pronged approach to helping people.
Right. And it's also important just in terms of really taking the family systems into context as well, because family systems really plays an important role in just long-term outcome for, clients, instead of just medicating. I think it's really also, I'm glad that we're having this conversation with this group of providers, because part of the solution is about educating non-psychiatry prescribers, right? In terms of the dangers in just looking at psychological issues and problems in living through a medical model lens and the dangers of that in the long term.
Well, and we've talked a lot about the issues of the kind of just the psychiatric view of people and wanting to medicate. Not, I think 90 or 95% of psych meds are prescribed by non-psychiatrists.
Yeah.
So by general physicians, by nurse practitioners, physician's assistants, and the fact is, most of their knowledge about meds are coming from pharmaceutical companies because they
Yeah.
know they're mined and dined by them, and so they're so prone to prescribe antidepressants, anti-benzos, anti-anxiety meds are
Mhm.
given out like nothing,
Yeah.
and that's where the real problem is, I think, in many ways.
Right. Right. So, and I've reviewed the multi-treatment, again, different modalities. It's so important for clients
Oh,
to.
one thing, did we mention open dialogue?
No, actually, do you want to
Oh,
talk a little bit about that?
let me tell you a little bit. So in Finland, there was a town, Tornio, that had a high incidence of what was labeled schizophrenia, and they developed open dialogue, which was basically sending professionals into the home in teams, but taking away their professional designation. So, going on first name basis, which is sort of what we do at PCH, is we try to see clients as partners and not, sort of beneath us.
Right.
They would do that. They would discuss people's voices, trying to sort of normalize them. And if it was too overstimulating for the person, they could go to the room, but they had to leave the door open and just listen to this team talk about these things. So I think a big part of it, and we have incorporated some of that at PCH with our Pasadena program, which is a bit more highly acute issues.
Mhm.
I think part of the medical system of when people are hearing voices is trying to suppress them
Right.
and try and medicate them. And so what open dialogue does, and what we try and do, is kind of normalize them, make them less if you
Yeah.
reduce the anxiety around them, they're less likely to occur, actually.
Right. It's a part of the experience, right? We're trying to get people in contact with their internal experiences, whatever those experiences are, thoughts, feelings, sensation, images, whatever they are, to get in contact with them and understand them, as opposed to trying to get rid of them, which is what the unfortunate reality of our current medical system. I know we're pressed for time, so we'll wrap it up real quick. But so in terms of PCH's approaches to med, right, we are, again, it's in terms of efficacy of psychotropic medication is limited. So what is the role in using medication in this kind of treatment model? It's about really how, if somebody is having difficulty with access to the treatment, how do we use an medication augmentation to help and facilitate that relationship, right? It's about appropriate medication and staying away from addictive substances. And so, in conclusion, it's really about, as I said before, the human condition, acknowledging what the human condition is. And there are uncontrollable experiences that we have from the inside. And that pain and these experiences are a part of life. At what we believe that what leads to suffering is the meaning that we make about those experiences and all of the attempts that we try to get rid of them. We also, again,
I
avoid.
was just going to say to that, where it says comfort with ambiguity, eccentricity, and individual differences, that's not an easy thing. I mean, when I
Yeah.
was in private practice, I'd have so many colleagues asking me to see a client of theirs because they became, they were psychotic, and that made them really nervous. And I think I remember hearing a guy named Bert Karam, who was a schizophrenia expert, it was many, many years ago. He said that we medicate people who are schizophrenic because we're afraid to hear what they have to say, because he felt they were more in touch with the kind of primordial dark side of human existence,
Mhm.
and it made the provider more comfortable to be able to kind of quiet them down. And
Right.
so to be able to be comfortable with really difficult human experience is not an easy thing to do.
Yeah, yeah. And that is a great point, right? And we brought up like cultural uniqueness as well. So we don't have time to get into all of that, but that is so important in terms of as treating professionals, that we don't see those things. If we are able to expand our comfort in this area, we're less likely to see things as pathologizing. Now, again, avoid using diagnosis to marginalize, stigmatize, and control people who don't fit in. That, again, we will be more open to that if we're increasing our comfort with ambiguity and just all of the human experiences. And then practice watchful waiting in our assessments, right, of what is going on with the individual. And then partner with clients in decision making, not as experts, but really just as collaborative people on this journey with our clients. And then help them to take responsibility and acknowledge consequences, good and bad, for their actions. And then, of course, premium no serum. How do we say that?
Primum no nocere.
Yes. In Latin, first, do no harm. Above all, do no harm. The one thing I wanted to say, again, the goal of PCH is, one of the clients said it best, is when she wrote this poem, she says, I will leave, so we are enough. And maybe I will go as far as to say, as people leave for the last time, California's sun, they will leave diagnosed, relentlessly resilient, stubbornly hopeful, brilliantly brave, courageously tenacious, and a warrior, always a warrior. And so that's our goal, is that the clients will leave diagnosed from PCH as a warrior to navigate and take on life experiences that come up. So wonderful. And now we are going to take questions.
Thank you both so much. It is great to see both of you. I wish we were in person, and just always appreciate listening to both of you so much. So in line with so many of the other presenters around medications that I've been hearing during this symposium. So, and Jeff, one thing I heard on one of your talks one night a few months ago, seems like now, where you talked about where the baselines and the norms in the DSM came from. I loved that. Would you mind to speak on that just very briefly?
You mean in terms of how things are decided in terms of diagnoses, or?
Yeah, originally in the DSM, who was that decided by?
Like I said, it's mainly white male, primarily psychiatrists, older white males, and their definition of what normal is. And so it tends to be pretty narrow. It tends to be very culturally biased. And one great example is, I think in the early 70s, before DSM-3, homosexuality was a disorder. Yeah. And they had a vote. And 55% of psychiatrists voted against it being a disorder, and 45% voted in favor of it. So, 45% still felt that it was a disorder. It's more of a political than a scientific document, basically.
Thank you. I loved your description of that. So we do have a few really good questions coming in. This first one says, for the record, I love this perspective, completely agree with it. I see so many teens today diagnosing themselves with ADHD based on symptoms they read online. How do you handle this? And I guess exacerbating that a little bit more would be talking about how a lot of people, parents diagnose their children, teachers diagnose students, none of them having the training to do so. So how do you de-escalate someone that has been misdiagnosed or diagnosed themselves?
I think these terms have become so much part of the culture in the vernacular, like OCD. People say, oh, it's my OCD. Like I said, the example with my own kid. And, part of it is what I do is, if you look up the diagnosis of ADHD, we all qualify for it to a different degree. And I remember reading a study that goldfish have a longer attention span than the average human. Maybe, they have less to think about. They think about flakes of food on the surface of the water. But, all of us, there's so much stimulation coming that all of us have that. And certainly that's not to suggest some people have more problems paying attention than others. But again, we tend to look at context, and I think it's grossly overdiagnosed and over medicated. And you know, I've had young people come up and say, you know, your psychiatrist won't give me Adderall, and you know, I've been taking it for a long time, and I do better on it. And I say, well, short term, we all do better on it, but until it makes you, you know, get addicted and become impotent down the road. But
Psychotic.
or psychotic, I know. So, you know, I think it's more about educating people about what these diagnoses are and where they come from, and that they're not very accurate, and that the medications have their own problems as well. But Adriana, do you have anything to add in terms of?
Yeah, I was also thinking, just as a society, as you talked about, just so much stimulation coming in, we're really not training our citizens to learn how to pay attention. It's so sad. In going just to like the restaurants, different places, I see young children being placed in front, and I'm sure many of the folks in this room might be able to relate to this. How many of you have gone to a restaurant and you see a family out to dinner, and all of them at some point, what are they doing? Right, they're like this on the screen. So we are moving further and further away from how we actually gain the skills to be able to sustain attention, the kind of attention that's required for not so entertaining, stimulating tasks like in school. So no wonder we're seeing so many kids having difficulty paying attention to tasks that are meant to develop the part of the brain that this part, you know, this little machine here is not. So I do think it's a real problem just culturally as a society that we do have to address.
I might add too that, you know, while we don't accept the terms and the kind of diagnosis, we do treat the problem. So, you know, attentional problems are real. And I'll give you an example. When my kids were 5 or 6, they were, you know, they had some attentional issues. I brought a neurofeedback machine home and hooked them up. They didn't love it. And particularly the machine pauses whenever you're not paying attention. So to get through with the program, they had to learn to pay attention. So it may have just been behavioral, but it really helped. And that's what we do at PCH is we do neurofeedback. We do lots of multi-pronged kind of approaches to help people regulate better and pay better attention.
And I would say, David, that about 95% of the clients who come in with an ADHD diagnosis, after we actually do our testing, most of those diagnoses that they come in with are given by either a psychiatrist that they saw or someone they saw for a very short visit, just based on self-report measures. And after we do a comprehensive assessment, about 95% of these individuals truly do not have the kind of attentional problems that they truly believe that they had all these many years. And so we're really just trying to help them learn how to develop the capacity, the skill of paying attention without medication.
Yeah, thank you for mentioning about general practitioners too. You know, that's kind of been a thorn in my side for a long time. You know, that somebody comes in and they get put on a bunch of anti-anxiety meds, and the doctor obviously doesn't have time flipping one flag to the next to investigate to see how much cocaine they're actually doing. And they're, you know, on a bunch of cocaine and they're given anti-anxiety meds, or they're very depressed and they give them an antidepressant and they're, you know, sucking down a liter of whiskey every day or something, it's just doesn't make sense. And kind of on a grim note, during our break, I found out a physician that I've known for years and highly respected and loved. This guy passed away. And one of his terms was always, there's not a medical solution for a spiritual problem. And, he defined a lot of trauma as being a spiritual block and a spiritual issue as well. And so, so that really made me think about him as well.
And David, I'll just add, sometimes it doesn't even, not even a visit. Someone will call their physician and they will prescribe over the phone without even seeing them.
You can do that online now.
Oh yeah.
So one question, do you, what do you use in reference to like nutritional therapy? For instance, at our facility, we have no refined sugars, which a lot of our people also agree that that was probably the first drug that they ingested. So we don't have any refined sugars, and we don't have any dairy as well. And so trying to get them to have a healthier lifestyle around nutrition. And my belief, and you can agree or disagree, you can tell me, but by taking those refined sugars away while they're in treatment, can hopefully expedite some of the healing of the brain and be able to absorb more of the therapy that's going on.
Yeah. Well, we're not quite there yet, David. I certainly share, just from a personal perspective, some of those same beliefs, just in terms of processed food and how that impacts us. However, what we do with our clients when they come in, each of them have a wellness assessment. So we're looking at all of the different dimensions of wellness, including your physical wellness, which includes a subcategory of that includes your diet and nutrition. And based on their report from the nutritional assessment, they're then referred to a nutritionist for a private consultation to discuss their unique needs as it relates to the struggles that they're having in their lives. And that nutritionist then works with them to put together a program for them that they believe would be best helpful to their recovery. Yeah, so, but we're not there in terms of completely eliminating refined sugars or dairy from our diet with our clients.
And the socioeconomic discrimination is something I really have not thought about a lot. Where people of color are over-medicated or mismedicated or overdiagnosed or whatever that may be. So I see some huge discrimination. Can you speak just a little bit more about that? What you've seen?
Yeah, what I've certainly seen, and Jeff can talk about what he's seen and also read about, is certainly people of color tend to, it's a double-edged sword, because depending on the issues. So I'll talk about stuff such as schizophrenia, other kinds of really severe diagnosis that can really impact someone's life forever in terms of being stigmatized and labeled. People of color tend to get more of those diagnoses. On the other hand, when you're looking at just medical treatment, people of color tends to get less medical treatment, less pain medication, which I believe in part has contributed to the opiate epidemic in mostly white individuals. Because when a Black person or a person of color goes and discusses pain, because of the implicit bias and beliefs that perhaps people of color can tolerate more pain, we may not be conscious of it, that leads to prescription differentiation in terms of pain medication. So it is this double-edged sword where there's certain areas where Blacks and people of color may get diagnoses that are more severe and not get the treatment that they need in other cases, but then you can see how it is a disservice to the other culture.
And, I might add, related to the kind of diagnostic system that, is mostly created by white males. And it also discriminates against women over history, that women were seen as hysterics and borderlines and tranquilized. My mom had some anxiety and she was on Milltown in the 60s and Valium in the 70s. And then it was Dalmane for sleep. And they tend to, again, women, it's another way of social control, of quieting people down. And that's a whole nother topic, but
yeah, we could have a whole nother session on just
Yeah.
that. My aunt and my mom and several others, always had mother's little helpers around, the nerve pills, as
Exactly.
they referred to. So then do you see many mental health diagnoses that are actually untreated trauma? And I know you spoke on this a little bit, but could you exacerbate on that a little bit?
Well, I think, like I said, just about everything we treat, there's a trauma underlying it. And even, I remember having a client years ago who was very suicidal and she got, put into a hold in a psych hospital, and her roommate was psychotic and thought she was a vampire. So this poor girl couldn't sleep all night because she had to watch this. So, I mean, it can be really traumatizing to be placed in a psych hospital itself with varying degrees of acute illness or problems, and it can be very scary. And we often are treating the trauma of that when someone comes out, aside from the facts of being so controlled and locked down. But I remember with a previous clinical director arguing with me. He was big into mentalization about borderline personality, and looking out in the patio and saying, well, what about her? She's got a you think she has a borderline diagnosis, don't you? And I said, well, she was raped when she was young. She has trauma. Almost everyone you can point to with these kind of severe diagnoses have some level of trauma. That's not saying there aren't other things going on as well, with bipolar, for example, but those are the kind of things that will trigger a mania, for example, is a memory or a traumatic event or stressors. So I think it's something that, I think I've debated with some psychiatrists who say they think trauma is way overemphasized, and they're only looking at PTSD, at what fits the DSM diagnosis. And I think they're missing all the small T traumas and other kinds of traumas that we experience in this culture.
And that we all, and culturally affect us differently. But, I use the example of, my parents get divorced, Adriana's parents get divorced. It might just be to Adriana, well, this is real unfortunate. We'll get through this. I'll see, it might take me completely off the deep end. So it affects everybody much differently. And I think we need to think about that when we're dealing with people individually, how things affect people differently and culturally differently affect us.
Well, and the context that's the main thing, is we just look at context for everything. And, again, you can't live in this country the last 4 or 5 years and not have different varying degrees of trauma, from, political stuff to pandemics to everything else, to all the George Floyd murder. All of this stuff is traumatizing to different degrees to different people.
Absolutely. And then I was just curious myself about NARM. And when Adriana mentioned bottom up, made me think about NARM, and wondering if you're utilizing any of the NARM modalities of treatment at this point yet.
David, I'm actually not, when you say NARM, what modalities in NARM?
Neuroaffective relational model.
Okay.
It has taken off across this country, came from the UK, and I'll be glad to share some stuff with you if you want to talk to one of our therapists that I think she's getting close to being a trainer of NARM. It's very, very interesting. They absolutely love it. They also love neurofeedback, and having that barrage of different ways of coming about trauma, because what works for one may not work for EMDR, won't work for somebody at all, works great for somebody else. They're really taking off with NARM.
Would love for you to send me some information on that. No, this is my first time hearing of that, so thank you.
Oh, absolutely, I'll be happy to share. Let me make sure there's not any last questions in here. You talked earlier about self-fulfilling prophecies. You used the example of someone who might use bipolar disorder to explain behaviors.
That's actually borderline personality disorder, I think they're talking about. About borderline. That's been an issue. We'll get people from a psych hospital who will come with a borderline diagnosis, and they're very attached to it. And the family is. They say, well, now explains them. And often we'll just try and explain to them that we don't think it's a useful diagnosis, that we think it's very pejorative. We feel like if you look it up on the internet, you're going to have this for life. We don't believe that. And we believe more in a trauma kind of model to work with that, and that we help people learn to regulate better and trust more, and that they wouldn't carry that diagnosis, but hopefully by the time we're done with them. So that's how we will approach it.
Yeah, and we usually outline as they go through their life narrative and their history, how we see the connections between what their experiences have been and how they are relating in their current relationships and currently with the world. And so we provide that different kind of perspective to them. And the majority of them actually are able to say, you know what, that makes a lot of sense. Thank you. And able to adapt that different perspective. And then a minority of people are really still wedded to that BPD diagnosis. So it just takes more time. And as they go through our model and integrate into the community with the other clients, then of course that peer kind of influence sometimes able to shift the perspective for those remaining few.
It's always hard when there's secondary gains from a particular diagnosis of someone not having to take responsibility, not having to work, not have to really work with that. And I think it's the same with a lot of these.
Right, right. Well, listen, thank you guys so much. It is very good to see both of you. I hope it's in person in the near future.